So thyroid nodule, thyroid cancer, v46. A 55-year-old female is referred to you for further evaluation of thyroid nodule that was incidentally discovered on 18 FDG PET performed in the investigation of a recently diagnosed breast cancer. How would you further evaluate this thyroid nodule? So nodules detected with PET CT, they have a high chance of malignancy. So I will start with clinical evaluation, complete history, physical examination, focusing on thyroid gland and adjacent thyroid lymph node. The history should include the factors that increase the pregnancy risk like childhood irradiation of the neck, total bone irradiation for bone marrow transplantation, exposure to ionizing radiation for nuclear fallout, familial thyroid carcinomas, rapid nodule growth, and hoarseness. Biochemical evaluation by doing the serum TSH level, and radiological evaluation is determined by the TSH and thyroid state. If TSH is low, indicating a hyperthyroid state, a radio, then I will do preferably iodine thyroid scan should be performed. This will indicate if the nodule is hot, hyperfunctioning, risk malignancy is lower. If the TSH is normal in the patient is euthyroid, the thyroid ultrasounds can be performed by experienced radiologist, and then FNAC can be performed if it's more than 1 centimeter. The cytology reports indicate that this lesion is cytologically indeterminate and gives a grade of THY3F. What are the possible diagnoses? What is the likelihood of the malignancy? The 3F means it could be follicular neoplasm. The histological differences include the hyperplastic nodule, follicular adenoma, follicular carcinoma, and follicular variant papillary thyroid cancer. So follicular indeterminate cytology is found to be malignant in 9 to 40% of the cases, the risk being highest when suspicious radiological features are present. How would you proceed with further investigation? I will perform a diagnostic hemithyroidectomy. Would you perform an frozen section? No. Histology came at 3.5 centimeter follicular carcinoma. How would you decide on further management? So we will discuss him on our MDT setting. Size of tumor is used to determine whether the further surgery is necessary. So for tumors, all follicular cancer more than 4 centimeters should be proceeded with completion total thyroidectomy. For tumors more than 1, less than 4, other risk factors should be taken into account by MDT when deciding whether to proceed to total thyroidectomy. These include age more than 45 years, widely invasive tumors, lymph node, distant mets, and angioinvasion. What surgical approaches may be considered? Open, minimally invasive, robotic. In all cases, patients should be informed of surgery risks equally, including recurrent laryngeal nerve injury, postoperative hypoparathyroidism, hypocalcemia, postoperative hematoma, scar formation, lifelong requirement of thyroxine, total thyroidectomy. If we do proceed to procedure completion thyroidectomy, is a lymph node dissection required? So lymph node mets are found in 1 to 8% of the follicular thyroid carcinoma because they're more common in papillary. So if proceeding, so I will do the ultrasound neck. If any found, we will do the FNAC. If FNAC is positive, then we will do the nodes. What are your management consideration in immediate postoperative period? Following completion thyroidectomy, serum calcium should be checked. If less, it should be replaced. If patient voice change, so patient should have direct laryngoscopy. Thyroid hormone supplementation should be guided by the requirement of radioiodine remnant ablation. If patients are planned to receive radio remnant ablation with recombinant TSH, they should be commenced on suppressive doses of levothyroxine. If a thyroid hormone withdrawal protocol is to be followed, then T3 should be commenced, then stop 2 weeks prior to scan. What are the indications for radioablative radioiodine remnant ablation? For definite indications include large tumors, tumor size with gross extrathyroidal extension, and distant mets. So radioiodine remnant ablation can also be considered for patient with more than 1 centimeter and less with the adverse prognostic features such as the poorly differentiated, widely invasive histology, multiple lymph node involved, large size of one node, and so extra capsular nodal involvement. These cases should be discussed in multidisciplinary context.